morning, good afternoon in India. I'm Jens Seeberg. I'm a medical anthropologist based at Aarhus University in Denmark, and I've been working with tuberculosis in India since 2003. Let me just quickly thank the organizers, NIRT, Dr. Kariklan, Christopher Pell from Sonar Global, Karlin Hofstraat, and of course, Director of NIRT, Dr. Padma Priyadasni, and also from Sonar Global, Tamara, for making this great symposium possible. The theme of this symposium is important. It's critical to the success of the fight against TB, and I really look forward to hearing the presentations from good colleagues from around the globe, and not least from India, where I've lived for around 6 years. It was great to hear Dr. Shona's presentation, even though it's also tough input, as it does realistically depict the difficulties that DRTB patients face. And I do have to say that I recognize the points from my own work in drug-resistant tuberculosis. However, my own presentation today will be different. As you can see, I've changed my title a little bit, suggesting that tuberculosis is not just a social condition, it's a biosocial condition. And the reasons for this, I hope, will become clearer as I move ahead. My presentation has 3 parts. Can I just ask, do you have an annoying black thing on your screen? It comes and goes when I move my arrow. I try to not do that. Anyway, my presentation has 3 parts. First, I'll share some personal experiences with social science input to TB control in India from my work as health systems research advisor to the Dinito-funded TB project in Orissa, which worked very closely as part of or in collaboration with RNTCP until 2005. Then in part 2, I'll share some key social science concepts, and in part 3, I'll suggest what I see as some of the most urgent social science research topics at present. So part 1, 2 examples of past social science contributions to TB control in India. And I do share this with humility, fully recognizing that in the long history of TB, and not least in view of the contribution of NIRT, these are very modest examples that I'm sharing. Now, information, education, and communication, commonly abbreviated as IEC, and with a host of later varieties and related acronyms, was not a particularly strong part of the DOTS program as initially promoted by the World Health Organization. But in Orissa, it was taken up and developed with tireless zeal by the late Mrs. Shanta Ray, whose pioneering contribution I'd like to acknowledge here. She developed a wide range of participatory communication approaches, from street and puppet theater to various forms of community dialogue to radio spots. This was before social media, really. And these initiatives stimulated local community participation in TB case detection and care and support to TB patients during the course of their treatment. I was lucky to get to collaborate with Mrs. Santa Ray and use my social science background to help consolidate her vast experiences as well as other input and systematize it to become a strategy based on 7 principles, namely the universal right to know, cultural sensitivity, gender sensitivity, community participation, multi-level partnerships, appropriate media mix, and research monitoring and evaluation. The strategy was developed in close collaboration with Central TB Division, and the resulting health communication strategy for RNTCP was adopted and published by the Government of India for use at district level all across the country. Now, the other case is also from the same project, but very different in nature. It concerns a part of Malkangiri district in India, in Orissa in India. And this part of the district is known as the cutoff area because the Balimela Dam, which opened in 1962, created a part of land that was locked between the water reservoir and the mountains, and where 30 to 40,000 people wanted to stay because of ancestral ties to the land. You see this area above the water on the map, the small area there. And as you may see from the map, there were no TB services in the area until 2004. In consultation with Government of Orissa, we decided to try to make TB services accessible in this area. We designed 4 baseline studies on access to healthcare in general, on social distance to healthcare providers, on the situation of DOT providers in the district, and on the health and nutritional status on both sides of the reservoir of communities. The findings were published in this open access monograph, and if you're interested, I'm happy to share it and provide a link. Anyway, on the basis of these studies, we also developed a package of interventions to test a tailor-made tribal access model. For those not familiar with India, let me just note that the concept of tribal populations was laid down in the Indian Constitution. Anyway, the objectives were to increase access to directly observed treatment in tribal communities. We did that using what we call a neoliterate or concept of neoliterate or category of neoliterate DOT providers. And we developed a pictorial treatment card that would allow them to monitor treatment. We also provided extensive supportive supervision or developed a new category of supervisory staff, so-called tribal area supervisors that were recruited from these areas themselves and hence were culturally and language-wise competent. We increased access to diagnostic services through sputum collection centers, and we improved provider communication to reduce misunderstanding and mistrust between providers and patients. This was the pictorial treatment card that was developed for neoliterate DOT providers to make community engagement possible. Now going back to the map, as you may be able to see, the small blue dots are DOT providers, the existence of DOT providers, and the red ones, larger red ones, are microscopy centers, and this is before the intervention. This map shows the difference after the intervention. Now, the small red dots show the non or neoliterate DOT providers, and the larger blue dots show the sputum collection centers. And the difference in terms of access is striking between the two dots. And you also see now in the cutoff area at the top of the map, there is a good spread of service providers and basic access to diagnostic services. So in terms of the outcome of the intervention, we thought it was very promising. And again, this is back in 2004 and 5. So what we saw was that access to RNTCP services at community level increased dramatically as a result of the intervention, as most villages in the intervention area now had a trained DOT provider. The social distance between DOT providers and patients was essentially eliminated. Community DOT providers, which was the term we used for the non and neoliterate DOT providers, were able to fill the pictorial card very satisfactorily. Directly observed treatment was increased to cover around 83% of cases, which was way beyond the baseline. Case holding improved as irregularity of treatment was promptly addressed. No defaulting was observed among patients treated by the new community DOT providers, as in 0 cases. Community DOT providers provided IEC to their community and referred cases for sputum test, many of whom were positive. So we thought that the role in case detection could be further strengthened following the intervention, and supervision of the neoliterate DOT providers was tailor-made so as to improve their basic skills and confidence in something as simple as using a pencil and filling the card. Now, using a pencil to fill a card is not a given thing if you had no access to education in the first place. So this was really a cutoff area. Now, what happened was that the concept of community DOT providers and the pictorial treatment card became very popular, not only in the cutoff area, but also in many other difficult to reach parts of the districts in other blocks. So on its own, I believe this intervention was a success. However, let's now look at the wider take-up. And this is, of course, a question of lasting impact. And I want to briefly discuss both of these 2 cases. Now, this is the website, today's website of TBC India. As you may be able to discern in the pull-down menu that I've opened, IEC has been developed by Government of India way beyond the 2005 strategy. And it also now takes the development in digital communication into account and does really a lot of things that were outlined in the strategy. So that that was, we believe, a very good input to that process. You may also note, if you can, and I'm not sure if this is hidden behind the participant view, but to the right under news, there is a quite small box I've highlighted on Tribal TB Initiative. Now, this perhaps indicates that in the case of the Malkangiri project that I just described, we as social scientists were not able to secure the leverage for the lessons learned to effectively enter wider discussions. There could be various reasons for this, and I think timing is important. But what I remember was quite a strong resistance from the World Health Organization, who at that time clearly pushed a one-size-fits-all version of DOTS. And our findings that, and as Shona also just described, that a locally engaged and embedded approach was far more effective. This was not very popular with WHO at that time, even if it was quite positively received by Central TB Division in Delhi. Now, of course, this has changed, but it does raise the more general question, how to ensure that social science input is not lost when perhaps the timing is not ideal, and also when new actors, and in this case of the Tribal TB Initiative, it's USAID who supports it, when new actors enter the stage. Let me now move to something quite different. I want to just drop a few or mention a few key social science concepts. And so I'll be slightly more theoretical for a moment. After all, what social science does is also to produce theory and concepts. And I really don't see any contradiction or conflict between the more academic side and the applied side. I think they need each other. So with that in mind, let me just briefly introduce three concepts which may be familiar to some and new to others. The first, and the reason for my change of title, is the biosocial, the concept of the biosocial, which moves a little bit beyond the claim that tuberculosis is a social disease. The biosocial is based on the claim that all biological life is social, from simple forms of biochemical communication without consciousness to increasingly complex and conscious forms based on symbols, semiotic systems, language as we know it. And it claims that no form of life can survive without engaging with other forms of life. Such relations are by definition social. Communication is a form of social exchange. So in the case of TB treatment and development of drug resistance, a biosocial analysis seeks to understand the social exchange relations between bacteria and host and medical and other substances which may have toxic or nutrient characteristics, and the wider social network and health systems and the societal context. So this assemblage, this biosocial assemblage constitutes the configuration of TB and drug-resistant TB. So we need to understand how that works in order to really get a hand at development of drug resistance, for example. Now, the other concept I want to mention is the concept of configuration. I'd argue that it is possible to understand antimicrobial resistance as an undesired product of over and underuse of antibiotics in much the same way as, say, air pollution may be a product of diesel and petrol-driven car transportation, or landslides may be a product of deforestation on mountain slopes. So AMR, then, antimicrobial resistance, is a product of particular patterns of interaction between microbes and medicines and humans. The concept of configuration points to a distributed production facility alongside the positive effects of antimicrobial use. This allows AMR production to take place on a large scale. So we need to analyze antimicrobial resistance as a configuration from this angle, and this entails studying the product and its production and its reproduction in a reinforcing feedback process in which resistance is simultaneously configured and configuring. Finally, and I believe Tamara hinted to this concept, the concept of syndemic. Now, comorbidity at the scale of epidemics has been conceptualized as syndemic in response to the dominant biomedical conception of diseases as distinct entities in nature, located in specific organs, separate from other diseases, and independent of the social and cultural context in which they are found. And social science, in contrast, may claim that a syndemic perspective allows us to think about disease in relational rather than categorical terms, and to consider the importance of interacting social and environmental conditions that promote the spread of disease. In syndemics, the health effects of comorbid conditions are not additive, they are multiplicative. The mutually reinforcing dynamics of coronavirus and tuberculosis is a current example. Other examples of syndemic dynamics include tuberculosis and HIV/AIDS, and tuberculosis and diabetes. Now, keeping the concepts of the biosocial, of configurations, and of syndemics in mind, I'll now end my talk with listing some current topics for TB research. The first is to look at systemic triggers of drug resistance. And I think this is very much in line with Shona's talk as well. DRTB may be seen as a case of AMR. I believe there it has become quite clear that many of the same forces that drive AMR also drive drug-resistant tuberculosis. This could be a topic for a larger talk, but for now, let me just point to the complex relations between the public and private sector, which indeed often overlap in spite of conflict of interest in many cases. So here the role of the pharmaceutical industry also deserves further scrutiny. A second current topic concerns mobile populations across healthcare borders and boundaries, for example, state and district boundaries. The corona crisis has highlighted some of their vulnerabilities, but also outside the pandemic, they are particularly vulnerable when it comes to other infectious diseases, including those that may develop difficult to treat forms of AMR, such as drug-resistant tuberculosis. Here, the fact that they are often detached from supportive social networks and other resources available at home heightens such risks. But we need to know more in order to improve their conditions, and so doing also tackle the spread of AMR. Thirdly, multi-species tuberculosis. Whereas TB can attack a wide range of animals, humans among them, and hence serve as reservoirs for TB. Recent studies from NIRT have shown that animals can also be infected by humans with drug-resistant TB, and so there's a risk of development of a reservoir of DRTB in livestock. This clearly demonstrates the importance of the concept of the biosocial and deserves careful attention from a One Health perspective. For living with TB, DRTB, and other morbidities in what I would call a more than program perspective is really very much what Shona has already highlighted. What are the everyday decisions among both patients and their families and healthcare providers that may enhance or decrease the risk of development of drug resistance in the individual TB patient? Can we map these vulnerabilities and develop more attentive programs in line with some of the initiatives taken by the government of India, for example, in the area of nutritional support? The careful use of long-term ethnography for this purpose is crucial. And finally, the syndemic impacts, such as understanding the dynamics between TB, coronavirus, and diabetes, exploring much more systematically and from both the patient and a public health perspective, the dynamics of syndemics has become more crucial than ever with the successive waves of coronavirus hitting country after country. We know little as of now regarding the long-term impact of these dynamics on tuberculosis, but it is an urgent research agenda. Adding other syndemic dynamics to the mix, such as diabetes or HIV/AIDS, increases the complexity. But then again, this is the complexity that victims of these diseases face every day. And as social scientists, we can make important contributions to address them. Thank you for your attention.